Dear colleagues, let me introduce myself and my research topic. My name is Boglárka and I am working at the Semmelweis University Heart and Vascular Center. My vision is to help heart failure patients receive the most effective evidence-based therapy, and my mission is to conclude from observation which we can include in the everyday clinical practice. I have two specific goals. We would like to investigate heart failure patients with devices, especially cardiac resynchronization therapy. Let's see our first project. The title is The Benefits of Adding a Defibrillator to Cardiac Resynchronization Therapy. It is a systematic review and meta-analysis. As we know, CRT is an effective therapy in selected patients with heart failure and severely reduced left ventricular function. CRT has two types. One is with a defibrillator function, especially for patients with high risk for malignant arrhythmias, and one is without a defibrillator function. It can only pace and resynchronize the chambers. However, the benefit of adding a defibrillator to CRT is natural, because no head-to-head randomized controlled trials have been designed to compare these two treatments. While CRT-D may further improve survival over CRT-P by reducing sudden cardiac death, it does also add defibrillator-specific risks such as lead failure and inappropriate shocks, as well as its costs. So our aim was to evaluate the benefit of adding a defibrillator to CRT and to compare CRT-D with CRT-P regarding all-cause mortality and cardiovascular mortality. Here you can see our clinical question and our PICO. So we would like to compare CRT-D with CRT-P, and our hypothesis is that CRT-D is superior to CRT-P. We conducted the systematic search, and we get 29 eligible full-text articles, which we can include into our analysis. But unfortunately, from these 29 articles, some hazard ratios are missing, so we could only include 24 articles. So heart failure patients have a high mortality rate. First we consider to evaluate the all-cause mortality. As you can see, the hazard ratio is 0.92. This means that CRT-D can reduce the mortality by 19%. We wanted to see all-cause mortality based on propensity score matching, because this is the most valuable way to investigate observational trials. We can include 8 articles, and the hazard ratio is 0.83, which means that CRT-D is also superior over CRT-P. It can reduce the all-cause mortality by 17%. We also performed subgroup analysis based on etiology and age. We can see that regarding ischemic patient, CRT-D is beneficial, while regarding non-ischemic patient, there was no difference between CRT-D and CRT-P therapy. Ischemic patients have a higher risk for sudden cardiac death and sometimes have larger or more scars. And regarding non-ischemic patients, non-ischemic patients have better improvement in left ventricular systolic function and left ventricular reverse remodeling due to CRT therapy. Regarding patients above 75 years, we can see that there was no difference between CRT-D and CRT-P therapy. Regarding this elderly patient population, the leading cause of death is not sudden cardiac death, rather non-cardiovascular death and from the comorbidities and frailty. And the progression of heart failure. We also performed the meta-regression because we wanted to see that over the years the hazard ratios were changed. We can see that over years there was no difference from the changing hazard ratios. So CRTD over years also superior over CRTP. We also shown the changes of the patient characteristics. The percentage of ischemic etiology and the percentage of male patient was decreased in the CRTD and CRTP population, but the mean age was increased. We could analyze 8 articles regarding propensity score matching, which is a prestigious data. We performed also subgroup analysis, and we did meta-regression also. Only observational studies were assessed, so this is the limitation of our study. So conclusion, based on our results, CRTD is superior to CRTP regarding all-cause mortality. CRTD is beneficial for ischemic patient, but patient above 75 years and with non-ischemic etiology could not benefit from CRTD therapy. And during the period of 20 years, CRTD still proved to be superior to CRTP. No time dependency of hazard ratios were found. We finished our article draft, and we would like to send it to internal review, and we will publish it maybe in the beginning of September. Our second project is related to heart failure patient and remote monitoring. The title is Continuous Invasive Remote Monitoring in Patient with Heart Failure Compared to Regular in Clinic Follow-up. As we know, annual hospitalization related to heart failure in the USA and Europe are estimated to be over 1 million. Remote monitoring in heart failure patient is an approach used by clinicians to enable earlier intervention in cases of disease progression. However, the guidelines is recommending remote monitoring at a high level, but there is no exact evidence for using it. In Hungary, 20,000 patients live with CIAD, and only 1,500 patients were monitored with home monitoring system. So remote monitoring is underused in Hungary. Our aim was to assess whether the use of continuous remote monitoring in heart failure patients lead to reduction in all-cause mortality, heart failure hospitalization rates, and cardiovascular-related hospitalization. Our clinical question, is continuous remote monitoring of heart failure patients with CIAD an acceptable alternative or way to regular in clinic follow-up? So we would like to convert this continuous invasive remote monitoring to regular clinic follow-up. We did the preliminary search. We have 15 eligible articles, and we are waiting from March to the statistician to do our analysis. Thank you for your attention.
I have one question. Regarding the second study, you include only ICD and CRT, and you don't include normal pacemaker patients?
Yes, we just include CRT and the ICD patients.
Mm-hmm. And what will be exactly the endpoint?
The endpoint will be cardiovascular hospitalization and cardiovascular death. Mm-hmm. So this will be the main endpoints, and all-cause mortality, of course.
Okay, great. Peter?
Just one comment. I would very carefully mention that we are waiting for statisticians for March, because it would suggest somebody who is not inside that we have really bad statisticians who is not looking after the student studies. I think all statisticians work really hard. it must be always discussion, of course always changing from your side the question, from the statistical side, from the answer. So I wouldn't put the problems to the other part. This is just one rhetoric comment.
Okay.
Thank you. It's important. We have to discuss several times with the statisticians. That's true. It's very important.
Congratulations to your presentation. It was very, very focused. Just one comment and not a question, but I think the National Healthcare Fund will be very, very satisfied with the first project if you have already published it, because they do not have to pay lots of money on elderly patients based on these results, because above 75 years they would just refer to your review or meta-analysis that you should not pay 5 times more money for the defibrillator device. Just implant the CRTP. I'm very sorry about it. A bit intriguing, but this is the truth that you have just showed us. I hope that they will let us implant sometimes CRTDs for mainly the ischemic cardiomyopathy patients. But this is a great job. Thank you.
Thank you.
And would it be feasible to conduct an RCT in this topic, comparing these two kinds of devices? I mean, is there any ethical barrier, for example?
Do you mean about the first or the second project?
First.
First. So it's not an easy question, because as I showed you this figure, the hazard ratios are not changing over the years, but today's the drug treatment are very improved regarding heart failure treatment, and also the technical parts of the CRT implantation is improved, and maybe in nowadays there will be not so much difference between the CRTD and the CRTP treatment, but if we will include a lot of patients, maybe there will be a little bit different, but it's a lot of money, so it's not an easy question.